All right, Ellen, whenever you're ready, I think we're ready to roll.
Okay, sounds good. Well, I'll just go ahead and get started then. So thank you everyone for having me. My name is Ellen. I am the stroke program coordinator at Avera McKinnon Hospital. I was invited here today just to give a quick refresher about stroke and talk about the different treatments that we do for stroke here at Avera and at a lot of the larger centers in South Dakota. So our objectives today are to understand stroke pathophysiology, recognize signs and symptoms of stroke, understand evaluation techniques, prioritize pre-hospital notification, and knowledge of stroke treatment and care. I like to start all of my presentations with a little bit of epidemiology about stroke, just to talk about why this is so impactful for our communities and our nation as a whole. Stroke is the leading preventable cause of disability in the United States, meaning it does not top traumas and things like that, but it is a preventable cause of disability. And someone in the United States has a stroke every 40 seconds. That means about 800,000 Americans have a stroke per year. Stroke care costs the American healthcare system $34 billion annually, and that number is from about 4 years ago. So that has increased significantly over the last few years with how much healthcare costs have increased. And that really is, stroke is a very, very expensive diagnosis for our healthcare system. Now, I don't usually like to think about things in terms of money, but one way to frame that is that the issue with stroke and not being able to treat stroke, if we wait too long to get treatment for a patient, things like that, if we don't do what we can to prevent strokes for patients, is that it usually isn't something that they come into the hospital and it's sort of a terminal diagnosis like other cardiovascular events can be, but it is something that leads to a lifelong disability for a lot of patients. And so that is what becomes so expensive for our healthcare system with stroke. And so that's why we work so hard to treat these patients really, really quickly, do everything we can in that immediate phase so we can treat them and hopefully get them back to their level of independence they were at before their hospital stay, and hopefully get them back to their regular life. So rapid recognition of stroke symptoms and communication is absolutely crucial in stroke response. We as a hospital system are very dependent on our EMS crews to tell us that this patient is incoming and let us know what their stroke symptoms are. We always like to say time equals brain, and we will talk about that in a little bit here, but that is the biggest portion of this, is that we have to get things moving as quick as we can. So a little bit of pathophysiology, we'll just do sort of a rough overview. There are two different types of stroke that we talk about. There are ischemic strokes, and then there are hemorrhagic strokes. Ischemia means a lack of blood delivery to tissue. And so what happens in an ischemic stroke is that all of those arteries that supply our brain tissue, one of them is clotted off or closed off, shut down for some type of reason. And then we lose that blood flow and we can no longer support the metabolic demands of our brain tissue. Brain tissue does not store glucose, it doesn't store oxygen, it doesn't store any sort of energy reserve. So it really depends on that constant flow of blood. The primary goal of treatment in ischemic stroke is to restore blood flow and thus minimize tissue death. The longer that blood clot sits there, the more tissue dies, and then the higher chance our patient has of a lifelong disability. Transient ischemic attack, these used to be called mini strokes. This occurs when there is a temporary blockage of an artery and a temporary stop in blood flow to that brain tissue. That is what you'll see is acute stroke symptoms that come on and then resolve pretty quickly. We usually say that the TIA is technically when symptoms would resolve within 24 hours. They do resolve much more quickly than that in your average TIA patient, usually within 30 minutes to an hour. The goal here for TIA treatment and care is to identify the cause of that TIA and then manage risk factors. So we still consider this to be a medical emergency. We still do all of the same workup for these patients that we do for an ischemic stroke patient, because this can be a sign of an impending ischemic stroke. So if your patient has really diseased carotid arteries and that is breaking off these small blood clots, that tells me that that patient is at risk to develop a very large blood clot that can cause an actual full blockage and a full stroke. So we will still admit these patients at least overnight, do the full workup, and then hopefully send them home better able to manage their health at home. The other type of stroke, sort of on the opposite end of the spectrum from ischemic strokes, are hemorrhagic strokes. There are two types of these that we'll talk about. There is intracerebral hemorrhage, so that means bleeding into the brain tissue. That is where blood vessels rupture, and then that bleeding happens right into the brain tissue in a very specific spot. What happens then, blood is very irritating to brain tissue. It will cause a lot of swelling. That will increase your intracranial pressure, and that can lead to rapid neurologic decline. The symptoms of ischemic stroke, because it's bleeding into a very specific portion of the brain, will be the same as symptoms of an ischemic stroke. These patients, hemorrhagic stroke patients, tend to be much sicker than our stroke patients. They have a much higher risk of morbidity and mortality than our ischemic stroke patients. These can be very difficult to treat because all we can usually do is try to control swelling, try to control intracranial pressure, but there's not a lot we can do once that stroke has happened. Then there is aneurysmal subarachnoid hemorrhage. That is where a cerebral aneurysm will rupture and then bleed into our subarachnoid space, which is the space that wraps around your brain. So these patients, because they have all of that bleeding around the brain tissue, that sudden increase of that crushing pressure on their brain tissue, they'll report having the worst headache of their life. That is very sudden onset. So we usually say if they go from no headache at all to about a 10 out of 10 headache within just a few seconds, that is what we would consider to be the classic symptoms of subarachnoid hemorrhage. Just so that everybody is aware, in the emergency setting, only about 50% of these patients will have any change in their mental status. So most of the, well, I shouldn't say most, about half of these patients will be up walking around completely lucid. They will not be drowsy. The only symptom that they have is that headache. And then if we ignore it, they can then rapidly decline as that blood sits in that skull cavity and continues to cause that pressure on their brain. So if you're out in the field and you have this patient who just, I don't know what's going on, I just all of a sudden have this horrendous headache, make sure that's at the front of your mind, this subarachnoid hemorrhage as a possibility. We do need to make sure we identify that and get that aneurysm secured as quickly as possible, which we will talk about when we talk about stroke treatment. Stroke symptoms, we always have to go over these are the very classic symptoms. We use what's called the BFAST acronym, and that stands for balance. So if a patient has a sudden loss of balance or really unsteady gait, really unsteady when they're up and walking, any change in their eyesight, that could be all of a sudden they are very blurry, they've lost vision in one eye, they can't see out of one side of their peripheral vision. Any changes to their face, the classic sign is that facial drooping that we're all pretty accustomed to seeing or aware of, or changes in sensation to the face, arm weakness, the A stands for arm, or any changes in their speech. That can be slurred speech, that can be they don't understand what you're saying to them, or they can't spit out words. Then it's time to call 911, time to respond emergently, time to get that patient to a hospital as soon as possible. Now, these stroke symptoms are indicative of two separate circulation pathways. We have an anterior circulation and a posterior circulation. The anterior circulation is supplied by your internal carotid artery that rises up off of your aortic arch. And so that supplies the front portion of your brain, which is your motor and your sensory tracts. Any stroke that occurs in that anterior circulation is what we would call a classic stroke symptom type of stroke, especially here in the upper Midwest, where our patients have a lot of carotid artery disease due to our lifestyle here. So these patients will have that facial drooping, that arm weakness, that speech change, those very, very obvious stroke symptoms. And then we have our posterior circulation, which is your vertebral arteries that then come together to join your basilar artery and supplies your cerebellum, your occipital lobe, and your brainstem, sort of those back portions of your brain. Be mindful that posterior stroke symptoms are pretty hard to catch. So if we have a patient who comes in and they just say, wow, I am just all of a sudden horribly dizzy, I have new onset vertigo, I've never had vertigo before in my life, they seem really discoordinated, their speech is very slurry, that can be signs of posterior stroke. Unfortunately, those are also symptoms of being heavily intoxicated. Those are also symptoms of patients who are heavily medicated. And so we do need to be careful not to jump to, oh, this patient is just highly intoxicated. We need to always be mindful that this could be a stroke and treat it as a stroke first while we're trying to control all those other pieces for that patient. Emergent stroke response. So what do we do when we have this patient with these stroke symptoms, and why is it so important? Just shy of 2 million brain cells are lost every minute during an acute stroke event. During these events, the brain is actively aging and dying for our patient, or that area of the brain is actively dying. And you can lose about 11 years of brain function in just 3 hours. I really like this picture. I know that it's just a plastic brain model with that somebody doodled on, but I do like this to show what is happening in that ischemic stroke event. So what occurs is you'll have an artery blocked, and this black portion is called your infarct core. Here, can you guys see my cursor? I'm going to pretend you can. I didn't hear a response. So the black part here is your infarct core. The blue is what's called your penumbra around that. And we use the same terminology for myocardial infarction as well, for heart attacks as well. But when you have that initial arterial blockage, you instantly have some tissue die. We cannot rescue that tissue, but you will have this big penumbra around that infarct core. That's brain tissue that is receiving a little bit of blood flow. We call it collateral flow from other vessels, aside from that main one that it is dependent on. As time goes on, that collateral flow will not be able to keep those brain cells alive. It helps to keep them sort of limping along, but not thriving. So over time, that infarct core will get bigger and bigger and bigger. So you can see at 30 minutes, we just had that infarct core, this big penumbra. At 2 hours, that infarct core has gotten significantly larger. We're losing that penumbra. So we're losing that tissue that we could still rescue. And then at 12 hours, we've lost it all. That's going to be a complete wipeout. We can no longer rescue that tissue. Now, these time increments are a little bit vague. They're not going to apply to every single patient, but that's sort of our hard and fast rule, is we want to make sure we get that stroke treated as soon as possible. So perfusion and oxygenation are our biggest things that we need right in that initial phase. So when we have this patient, we're on scene with this patient with stroke-like symptoms, or this patient rolls into the ED with stroke-like symptoms, of course, our main focus is going to be our ABCs. Just like any other patient, we need to make sure that we have a secure airway. We do like to maintain our oxygen above 94% for those patients, just to get that really, really oxygen-rich blood to that brain tissue if we can. We do allow what we call a permissive hypertension. We let these patients, until we can get some imaging done, we do let these patients run a blood pressure of up to 220/120. The reasoning for that is, in ischemic stroke, we want super high blood pressure because we want blood to be shoved into that brain tissue, and we want to get as much blood flow into that brain as we can. Now, understandably, that is not ideal for our hemorrhagic stroke patients. We don't necessarily want that super high blood pressure, but until we can get that imaging done, we always assume that it's an ischemic stroke because they are much more common than hemorrhagic strokes. If we have a patient come in with a blood pressure of 200/100 and we see that hemorrhagic stroke on imaging, then that immediately triggers us to get that blood pressure under control. We do like to have one or more large bore IVs in our patients with a fluid bolus. If able, we do instruct ambulance crews to give a fluid bolus when that patient is on their way in, or at least get some fluids going, depending on what your protocols are within your own program. We try to keep these patients flat if the patient will tolerate that. Obviously, if they don't tolerate that because of an airway issue, a cardiac issue, totally fine. But if they can tolerate it, we want them flat. Again, that is to allow as much blood flow to that brain tissue as possible. And then, of course, a rapid evaluation of symptoms. So the different assessment pieces that we do expect to see are the BFAST that we talked about earlier to identify stroke symptoms. We do like to have a blood sugar because very high or very low blood sugar can mimic a stroke, and we want to make sure that we get that fixed for the patient as soon as we can, if we can. And then we do use a large vessel occlusion evaluation. There are a few different options, but these are basically very short neuro assessments that identify symptoms of a very large vessel being occluded, and that can trigger our team to say, to go down different treatment avenues for that patient, which we will talk about. Other pieces that we like to know, if we are able to grab them from the patient history, what time did our symptoms start and what time what time were symptoms recognized in that patient? So patients, we like to know when they were last known to be completely without stroke symptoms. And then if we're able to, what time did those symptoms start? And now that sounds a little bit confusing, but one case to think about is if a patient wakes up with stroke symptoms. They were sleeping, they woke up, they tried to get out of bed, and they fell to the floor because their left side is completely flaccid. Well, what time did that patient go to bed? Did they wake up at all at night and go to the bathroom and they were totally fine at that point? Did they wake up and they went and made coffee and now all of a sudden they have symptoms? We really want to identify that last time they were known to be completely without symptoms. We like to know past medical history if we are able to. Of course, we can't always identify these things in that pre-hospital phase, but are they on any medications such as anticoagulants? Do they take aspirin? We want to know those types of things when they're coming into the hospital. Do they have a seizure disorder? Do they have any history of stroke, any cardiac history? And then for surgical history, what we're really worried about is a recent surgery. Did they have their knee replaced last week? Have they had a big back surgery really recently? Any big traumas really recently? Just because, again, that will help us make some treatment decisions. And then a family contact, if we're able to identify that, we do like to speak with family if we're not able to get a clear picture from the patient of what's going on. So stroke recognition and communication are absolutely key to timely treatment in the emergency department. We absolutely rely on our EMS crews to give clear communication ahead of time, including patient status, what were their symptoms, do we know what time things started? Again, that pertinent medical history, that all guides our hospital's response. Our goal is to have our stroke team ready in the ED when the patient rolls in. So here at Avera McKinnon, we will go ahead and call that stroke team when the ambulance is about 5 minutes out. And then our stroke team will physically meet the patient in the ambulance garage, do a really quick neuro assessment and get the ball rolling on what we're gonna do for that patient. The ideal situation is when we can also get the neurologist there with us. That's not always possible, of course, but it is always great to have them there with us as soon as the patient rolls in. So I'm going to talk a little bit about what our stroke team response here at Avera McKinnon looks like. This mirrors what is recommended by the American Heart Association and American Stroke Association of how a hospital is to handle that acute stroke response. So once that patient rolls in, we take them directly to CT with our stroke team. We are fortunate enough here at Avera to have a CT in our ED. That makes it really easy for us to get these patients right in. Our CT team completely clears the scanner for us when they know a stroke team is incoming, and that is very much designated for our stroke patients. Our stroke team is comprised of our ED physician, our ED nurse, an ED pharmacist comes with us, a neurology resource nurse, and a stroke coordinator. If I'm here, obviously I'm not going to come in the middle of the night for these, but when I'm here in-house, I do attend all of our stroke teams. We do have a pharmacist come with, they carry with them to the stroke team, to the scanner, our tenecteplase, and then they'll also bring usually a syringe of some type of IV push blood pressure medication, just in case we need to control that blood pressure, which we'll talk about. Treatment decisions are made based on our patient presentation. What does our imaging look like? What are our vital signs? And then that time of last known well. We do a few different stat imaging pieces, which I'll go into just a little bit of detail on for you guys. So we do that initial non-contrast head CT immediately. That helps us to rule out any bleeding. CT is a phenomenal imaging piece to identify any bleeding in the brain tissue. That immediately helps us to make a treatment decision. If we see hemorrhagic stroke, we're obviously going to go a completely different direction than we would if we don't see any bleeding on there. We will also immediately do a CTA, that is a CT angiogram. That gives us a really good picture of those blood vessels in the patient's brain, and identify any blockages if present. And then if the patient is a little bit further outside of their last known well, we'll do what's called a CT perfusion study. And that identifies any areas of what we call a perfusion mismatch. So this is getting a little bit more in the weeds here with this, but I did want to show you guys this picture. So the first one here, this is just a non-contrast head CT that identifies whether or not there's any bleeding. There's no bleeding on this one. And then we'll do that CT angiogram. And so that we inject contrast dye into the patient's vein through their IV, and then we watch that contrast come through these blood vessels. This patient has an M1 occlusion. That is a middle cerebral artery occlusion. A patient with an M1 occlusion is going to be a very classic stroke patient. That's going to be upper extremity weakness, facial drooping, probably speech changes, things like that. This can also help us see what does our collateral blood flow look like. So you see all these little bitty vessels out here. Those are going to be the blood vessels that give that little bit of flow to that stroke area, that area of ischemic tissue. And again, help that tissue kind of limp along for a little while until we can treat the stroke. And then this is that perfusion study. Basically what it does is it times how long it takes for that contrast to actually perfuse into the patient's brain tissue, and can tell us how much tissue is completely dead, we can't do anything to help it, and how much of it is at risk. So it helps us identify that area of penumbra. It's fancy pants technology. I don't understand truly how it works, but I do trust that it does a good job for us. So what can we do for this patient when they come in? So we've done that CT imaging. We don't see an area of ischemia. So we don't see an area of bleeding. So we assume the patient's having an ischemic stroke. What can we do now? So the first option, the gold standard for stroke treatment, is a blood thinning medication, a clot buster medication called either Alteplase or Tenecteplase. So the national trend is to be switching over to Tenecteplase or TNK. Most ERs are very, very comfortable with TNK. It is used in myocardial infarction as well. The dosing's a lot easier. It's just an IV push medication versus Alteplase. It has a really complicated dosing algorithm, and then it is a drip medication, which can be very complicated for some hospitals to manage in their ER. So our indications for a clot busting medication is the patient is less than 4.5 hours from their stroke symptom onset, and they have a measurable neurodeficit. That's really all they need to be qualified for a clot busting medication. There are, of course, several contraindications, really anything where we don't want the patient, anything that would put the patient at risk for bleeding. So a recent surgery trauma, a recent bleed, any recent anticoagulant use. So if the patient's on Xarelto, Eliquis, Coumadin, we do have special considerations for those patients. A super high blood pressure, we will get their blood pressure under control before we can give TNK. There's lots and lots of other ones, but these are those basic, straightforward ones. GI bleeding, if they have a Foley catheter in and they have bleeding with their Foley catheter, all of those types of things. Now, our next up option is a mechanical endovascular reperfusion. So that is where we physically go into the blood vessel and remove the clot causing that stroke. This is a relatively new treatment modality for stroke. That's a really, really revolutionary change to stroke treatment for us. This is a patient who has those symptoms that are indicative of a large vessel occlusion. We at Avera use the VAN assessment, so we'd call them a VAN positive patient. We see an occlusion on that CTA, which is that one that I showed you earlier, that MCA occlusion. We see that on our CTA. Their last known well has to be within 24 hours, and we know that we have a salvageable area of stroke on imaging. So we know that we don't have so much dead tissue that we can't reverse any of that for the patient. So this picture is just an animation showing how we do this. So we puncture the femoral artery, go up through the aorta, aortic arch, carotid artery, up into the cerebral vasculature with a catheter with a stent. So this is called our stent retriever. And so what we'll do is we'll weave the catheter up through that vessel, straight through the clot. As we pull the catheter back, that stent will expand. I like to think of it kind of like a Chinese finger trap. will expand. We let that sit within the clot, let that clot really get stuck onto that stent, and then we're able to pull that clot out, and that restores that blood flow to our distal artery there. So here's a better picture of it. This just comes out of a textbook. So this patient has that MCA occlusion here where that red arrow is pointing. So you can kind of see here that catheter is coming up into our vasculature there. This is our carotid artery, branches off into, this is our anterior cerebral artery that's nice and wide open. That's giving great perfusion to that area of the brain. But this is where our MCA should be. So you can kind of visualize with the negative space there. This is all brain tissue that needs to be perfused and is not being perfused. Picture B here is what happened after we were able to pull that clot out. So then that MCA is nice and open, and you can see how much brain tissue is now salvaged and how much function will be restored for that patient. This last picture here shows the blood clot that's actually removed. Sorry, that's kind of gross, but it just goes to show how big those clots can be and how much blockage we can have for that patient. So now we'll move on to hemorrhagic stroke response. Because this is bleeding and not clotting, we want to do completely the opposite of what we would do for an ischemic stroke. So just a refresher, the symptoms of intracerebral hemorrhage are the same as the symptoms of an ischemic stroke. So we don't ever want to give any type of treatment to these patients without confirming on imaging what's going on for them. And then symptoms of that aneurysmal subarachnoid hemorrhage, again, are that worst headache of my life, sudden onset for that patient. Some of them will actually hear a pop inside their skull cavity when that aneurysm ruptures, which is terrifying to think about. What do we do for these hemorrhagic strokes? So we've done our imaging, we see this area of bleeding. What are we going to do? It's really dependent on the patient and how much they're tolerating that area of blood in their skull. So now I'm 34 years old. If I were to have bleeding in my brain is nice and big and healthy because I'm young. And so if I have even a little bit of bleeding inside of my skull, that can cause a lot of problems. Now, our older patients up into their 80s and 90s, over time, your brain tissue will shrink and atrophy. That's a very normal process when you're aging. They will have a lot more room in their skull. So they can have a massive amount of bleeding and not a whole lot of symptoms. So we are going to approach that patient just depending on what they look like. Our main focus is going to be airway management, like always, very close neurologic monitoring for these patients. And then if we need to, we will take different avenues to control that pressure inside that skull. Our skull is a hard cavity. And if we have so much pressure going on in there, what can happen is your brain can herniate down through your foramen magnum, which is that big hole at the floor of your skull where your brainstem goes through. If our patient herniates through that foramen magnum, that will kill your patient. So we need to make sure we get that intracranial pressure under control. We do that through blood pressure control, pain management. We prevent seizures for that patient. If we have to, we'll put in what's called an external ventricular drain. That's just a drain that will pull blood and CSF out of that skull cavity, make some room for that brain. Or sort of a last ditch effort, we'll do what's called a craniectomy, which is a surgical procedure where we actually physically remove a piece of that patient's skull that allows that brain some room to swell and breathe. Again, that's a very last ditch effort. The risks and benefits to that are not great, but it can be a life-saving measure for a patient. No guarantee that they're going to have great neurologic recovery from that. So then aneurysm treatment, our main focus, if our patient has that aneurysmal subarachnoid hemorrhage, is to secure that source of bleeding. So what we can do is we can either coil it, so that's these fancy coils here inside that aneurysm. Those are made out of platinum. They're very hypercoagulable. They love to build up platelets and debris. What'll happen as blood flows in there and clots set off is your aneurysm will just be full of blood clot and it'll shut down. We can stent that aneurysm open, so you can see that stent here, and that will just kind of keep those coils up in that aneurysm, or it can block blood flow to the aneurysm if we need it to. That's called a pipeline stent. Or we can clip the aneurysm. Clippings are becoming more rare to see than stenting and coiling, because stenting and coiling is less invasive for the patient. To be able to clip a patient's aneurysm, we actually have to open their skull and find that aneurysm and place that clip on there. That's a really high risk procedure for our patients. And so we do prefer to stent and coil if we can. The only time we really clip anymore is if we can't get to the aneurysm and from an endovascular standpoint. Platinum coils, these stents, these are all MRI compatible, which is great for our patients. They won't set off metal detectors with those in their heads, all that kind of stuff. These clips, unfortunately, are not MRI compatible for those patients. So that's another reason we try to avoid them, is so that patients can go on to have MRIs if they need to for other health concerns. So that is aneurysm treatment. For every 10-minute delay between arrival at the ER and the start of stroke treatment, patients with severe strokes can lose 8 weeks of healthy life. So just kind of keep that in mind for why we move as quickly as we do in our ER in our stroke team scenarios. So our time recommendations here at Avera, we like to give tenecteplase within 45 minutes of our patient's arrival. Our record is 23 minutes. So that is very fast when you think about how many things we have to get done between them hitting the door and actually administering that medication to them. But again, think about how much of their life we have saved and how much of their brain tissue we save by moving that fast. For our thrombectomy patients, that's where we use that stent to remove that clot for that patient. We like to have groin puncture within 60 minutes. Our record is 8 minutes. We like to reperfuse that vessel within 90 minutes, and our record is 28 minutes for getting that vessel reperfused. So again, we move very, very quickly. We are very fortunate here at McKinnon to have a phenomenal stroke team that works really well together and gets things done for our patients really quickly. So the national standard recommendation for tenecteplase administration or alteplase administration on that clot busting medication is within 60 minutes of arrival. Okay, so I'll go through some patient cases here. So this is a patient who, again, some of these are, so this is just an animation. Obviously, I can't get an actual picture of that stent going in. But this is a 72-year-old male patient who woke up with right-sided weakness, neglect, a gaze deviation, which means his eyes were deviated to the side, with a last known well of 10 p.m. the night prior to arrival. The ambulance crew did a great job with this patient because they knew he had woken up with symptoms. They did have a conversation with him and his wife to say, okay, did you get up to go to the bathroom at all last night? Did you wake up and you felt okay? And then all of a sudden your stroke symptoms started to really identify. He was known to be well and without symptoms at 10 o'clock last night. So that tells us by the time he rolled into us, it was about 7 o'clock in the morning. He could not receive clot busting medications because he was well outside of that window. So that kind of helped us to guide our treatment modalities right away. So this CTA is showing that MCA M1 occlusion. This CT perfusion study, the purple part, that is our infarct core. That's dead tissue. We can't help that tissue. We can't do anything to rescue it. But this green tissue, this is tissue that we can save. So think about how big of an area of stroke we're able to reverse for this patient. We went in and did a thrombectomy. This is the before and after pictures. So that's a completely occluded MCA artery there, middle cerebral artery there. And then we were able to open it up, and that's the blood flow we restored. So this patient did pretty well. He did require a couple weeks on rehab just because he had other issues that contributed to this. He did have a lot of arthritis, things like that. So doing physical therapy was very challenging for him initially, but we were able to get him back home with his wife. Another case study of ischemic stroke. So we had an 89-year-old female patient, completely independent, fortunately, at her age. That is really lovely to see. She was staying with her daughter for the holiday here in Sioux Falls. She woke up with speech changes. She was unable to get out of bed. She actually grabbed her cell phone and called her daughter in the other room, which to me, thinking about my grandparents at 89 years old, would never think to call somebody on their cell phone. So I thought that was absolutely lovely that she called for help right away. Her daughter called 911 at 4:57 in the morning. EMS was on scene in just 7 minutes from that 911 call. They did alert ED staff of this incoming patient. They told us she's VAN positive, told us about her symptoms. She got to our ED at 5:26. The stroke team met the patient right in the ambulance bay. We confirmed that VAN positive status. We were able to get the first image of her stroke at 5:32. So just 6 minutes after her arrival, we had our imaging completed. She had an NIH of 32. So an NIH is our stroke scale that we use here in house. Goes everywhere from 0, which is absolutely no stroke symptoms, up to 42 is the highest that you can have. So 32 should indicate that she is very, very sick. She has very significant symptoms of right-sided weakness, facial droop. She was absolutely unable to speak to us. Her gaze was completely deviated off to the side. So she was very clearly having a large stroke. We did that non-contrast head CT. We did not see any signs of bleeding on there. We did CTA and a CT perfusion. She did have a left middle cerebral artery occlusion. Again, this is her perfusion imaging that shows this purple area is that dead infarct core. We can't save that little bit of tissue there, but we were able to save all of this green area here. This is a 3D rendering of that CTA. This shows us how much tissue or how much collateral flow she's getting, but really what is at risk for tissue there. So you can see how much brain we're losing very quickly for this patient. This is her before and after. So here is where that occlusion is. And then we got that open, and then here's how much brain is being reperfused. So really exciting to see. Her post-procedure NIH was a 4. So she went everywhere from a 32 all the way down to a 4. Just had a little bit of speech difficulty left and a little bit of weakness in her right arm, but otherwise was doing very well. She only stayed in the hospital for 5 days. Her NIH was 0 on discharge. She was back to being completely independent. She did do a little bit of PT and OT as an outpatient, just for some deconditioning. That's totally normal for us to see, especially at her age after being in the hospital, and she is back home independently and absolutely thriving. So we're always really excited to see those patients do so well. I know, just a little backstory from me. I am an old neuro nurse. I've been doing this for over 12 years now. And when I started as a nurse, we did not have thrombectomy anywhere in the country. That was not a possibility for patients. So we would have initiated a hospice conversation for that patient when she came in. So it's remarkable to see the things that we get to do now for patients and be able to get them home. So that's just really exciting to see. Another case study, this is about a subarachnoid hemorrhage. So we have a 47-year-old female patient. She was sitting having supper with her husband, and she had a sudden onset worst headache she had ever had. They did call 911. EMS came to scene. She told them this, and they did call ahead to our ED to say, hey, this is what we have incoming. She had a sudden onset worst headache of her life. We think she might be having some intracranial bleeding. So she came to the ED. We immediately called that stroke team again. She was completely alert and oriented. She was, her vital signs were totally stable. She had no weakness in her limbs, nothing else going on. But then very, very rapidly, her consciousness decreased. She ended up, or excuse me, her level of consciousness rapidly decreased after arrival. She ended up being only able to respond to painful stimuli within about 45 minutes of arrival. So thanks to pre-hospital notification, our ED team was ready for that deterioration. They had all the right pieces in place to say, we think she's bleeding. We need to make sure that we have an airway ready for her, that we have anesthesia right at the bedside for her, because we know she's going to go downhill fast. This is her non-contrast head CT. So what you can see here, we call this the hanging chicken. You can kind of see how this looks like a chicken, this white line there down the middle there. And that should be black. That should just be CSF in there. CSF shows up as black on a scan. Blood shows up as white. So if you think about this is just one slice of her CT scan. If you think about all these spaces around that brain tissue being filled with blood, imagine how much pressure is being put on her brain with that blood there, literally crushing her brain. So these patients can get very sick very fast. We were able to find her aneurysm pretty quickly on imaging. She had an anterior communicating cerebral artery infarct. I don't expect you to remember what that means, and that's fine, but here is how big that aneurysm is. It's about the size of a pea. We were able to find that on imaging. We were able to coil that, so you can kind of see those little clear, sort of look like a worm in there. That's the coil in there blocking that aneurysm, and here's a better picture of that aneurysm there. We were able to completely shut it down. And so then she did stay in the hospital for 3 weeks. That is every aneurysmal subarachnoid hemorrhage stays with us for 3 weeks for monitoring. There are a lot of complications that can occur after we shut that aneurysm down. So we do like to keep a really close eye on them. She did go home with just a little bit of home health for therapy, but no further symptoms. She is back at work full time. And we do annual imaging to monitor her and make sure that she's doing well. So she's doing great, and we're really happy to see her go home. She had a great outcome from that. So that's the whole story from me. Now we have a little bit of time for some questions. Hopefully get you guys a little bit back on track with your time today. What questions do you guys have for me? I can hear that someone asked a
Did you
question,
catch
but I
that one,
didn't hear
Ellen?
it. No, I did not hear that.
One of our guys in the room said there's all sorts of success stories that you can lose half of your brain and you can still be a politician. I kind of censored that just a little bit.
Oh, I appreciate that, but you know, that is correct.
Do we got any questions for Ellen? Anybody in the room? Anybody online?
I did that good of a job, not one question.
You did.
Oh
You did
man.
fantastic.